Cast is now starting. All attendees are in listen-only mode.
Hello, everyone, again, and thank you for joining us for another CEPA webinar. Today I have John Betcher, Director of the University of Texas Health Exercise Physiology Heart Training Program. And the title of his presentation is Basic Pacing Concepts. And the brief summary of this lecture will be on the basic concepts of pacing, including the types and codes of pacemakers and defibrillators, the components that make up a pacemaking system, basic electrical concepts needed to understand pacing functionality, and basic troubleshooting of these systems. Topics will also be covered are magnetic functions and the basics of remote monitoring. So I'd like to welcome John.
Thanks, Tim. Good afternoon, everybody. As Tim said, my name is John Betcher. I'm the director of the UT Health EP Heart training program for people interested in getting into the medical device industry. I spent 30 years of my life in the cardiac rhythm management industry with Medtronic and St. Jude Medical before having this job. So it's been a passion of mine for many years, and I wanted to kind of go over the basic concepts of pacemakers as I started my career as an exercise physiologist / kinesiotherapist in the VA system. And this kind of information could be very helpful because you see a lot of those patients in your daily activities. So what we're going to kind of go over is a high-level view of pacemakers, defibrillators, and heart failure cardiac resynchronization therapy devices. The slide deck is from Medtronic Academy because Medtronic has probably the best site, medtronicacademy.com. You can all go to, and there's a plethora of information about pacemakers and devices and those types of things, augment your education. And just want to give a shout out to them. Lots of the manufacturers have information about their specific devices, but Medtronic has a great presentations on generic things, just education in general. So for pacemakers, we're going to talk a little bit about electrical concepts, components, stimulation and sensing, or we call pacing and sensing, pacemaker modes, types of pacemakers, and a brief summary before we get into defibrillators. Basic electrical pacing concepts would be you have to have a pacing circuit. So a pacing circuit consists of a power source, which would be a pacemaker, or here is called an IPG, implantable pulse generator. Lots of acronyms in this business. A lead, which is a wire that goes from the pacemaker or defibrillator down into the heart, one of the chambers of the heart. And typically they get access for that through the subclavian vein just under the collarbone, and then into the superior vena cava, and then into the heart. On the lead, you have a cathode and an anode typically, which would be a bipolar lead, so it has two electrodes. The cathode is the tip, which is the negative terminal where the electricity comes out. The anode is a little ring on the lead, which is where the electricity goes to the ground and come back to the can. The final component of the circuit is the body tissue itself. So along that pathway is how the pacemaker works. Very basic electrical parameters for a pacemaker include voltage, current, and impedance. The voltage is the force that causes the current to flow. So if you think of your garden hose, when you turn the faucet on, how high you turn it on is your force. Current is the actual movement of electrons through the electrical circuit. How much energy is actually getting to the heart, and that can be a function of the lead resistance. It can be a function of how much insulation there is and what the tissue resistance is at the tip of the lead. Again, back to your hose analogy, it would be like if you kink your hose, you're going to have a lot of resistance. If you punch a bunch of holes in the hose, you're going to have a very low resistance because water is going to be escaping through the holes. And impedance is kind of the sum of all the resistances. It's measured in ohms. The main source of resistance would be the lead conductor, the tip electrode, and then the surface tissue of the heart. If it's scarred tissue or healthy tissue, can make a difference in the impedance and how much current gets to the heart. Why is that important for a pacemaker? Well, occasionally you'll have problems with the lead itself. You can have an insulation break, which would mean that some of the current is escaping through the break in the insulation before it gets to the tip of the lead. This can do a number of things. It can cause oversensing because if that current comes out and grounds on the anode, the device is going to think it's a heartbeat, and it can cause oversensing and lack of pacing. It can also cause a decrease in current getting to the tip of the lead, which can cause loss of capture or stop it, preventing it from pace. Or you can have a fracture of the conductor inside the lead itself, which is going to prevent the pacemaker from pacing because the current won't be able to jump that gap and get to the tip of the lead if it's a complete fracture. If it's an incomplete fracture, you can have a case where some of the filars or parts of the filament of the electrode are touching, and occasionally setting off over-sensing for that way too, because every time the electrodes touch, the parts of the conductor touch that are fractured, it'll cause a signal and can over-sense that. Typically, your lead impedance is going to be somewhere between 250 to 1,500 to 2,000 ohms. If you're below 300 or above 1,500, you typically start to worry that there might be some type of problem with the lead insulation or the lead conductor. Ohm's law is kind of the basis for pacemakers and how they work in terms of voltage, current, and resistance. We're not going to do any math today, but just for your reference, that's how it's defined. On a pacemaker programmer, you can interrogate these things. When you interrogate the device, it's going to tell you how it's programmed for voltage. In this case, you can see the red box shows the atrial leads programmed to 1.5 volts, the ventricular leads programmed to 2 volts, and they both have what's called a pulse width of 0.4 milliseconds, which is how long is the voltage turned on when it paces the heart. So 0.4 of 1 millisecond is all it takes at 1.5 volts to make the heart beat for this particular patient with a safety margin built in. The actual current being delivered to the heart can be measured through the device. It'll tell you 2.8 or 3.12 milliamps or whatever it may be based on the impedance. And it'll give you an impedance measurement. You see the red box on the kind of the bottom of the programmer screen there. It'll tell you what today's lead impedance was, 547 ohms for the atrium and 667 ohms for the ventricle. And you can see the trend plot there, a nice straight line, which is like to see. The atrial lead is right around 500 ohms for the past year, and the ventricular lead's probably been about 750 ohms, 700 ohms for the past year. So nice stable trends, which means the leads are functioning fine. You don't have to worry about insulation failure or conductor fracture. The components of the pacing system, the pacemaker itself's got a battery, circuitry, and a connector block. Fairly simple from that standpoint, but the circuitry is highly advanced. Basically have a mini computer in your chest. The leads or wires have a cathode and an anode, as we talked about before, unless the lead is what we call unipolar. A unipolar lead only has the cathode, and the pacemaker serves as the anode. So the current would go from the tip of the lead to the can in a unipolar pacing system. Body tissue is, again, the vast component of the pacemaker system. Here's your battery, circuitry, and connector block where the leads fit into the device. They have to be secured with a little set screw. Lead characterization, many things we can take a look at: position, fixation, lead insulators, electrode design, and polarity. For position, you can put them either in the endocardium or the epicardium, so either in the heart or on the outside of the heart, depending on how the procedure is done. The vast majority of cases are done endocardially, so they make a stick to gain access to the subclavian vein, as we talked about before, and introduce these leads into the heart through the subclavian vein down through the superior vena cava. Different types of leads for different chambers and different fixation mechanisms. If you look at the leads on the left-hand side of the screen, the first lead you see, it looks canted. That lead is actually used for pacing the left ventricle by putting it into the coronary sinus and fishing it over to a branch off the coronary sinus that's get down to the lateral portion of the left ventricle, kind of on the outside of the heart, although kind of mixed between inside and outside of the heart because you're in a vein. The next lead over to the right is a tined lead. Those little silicone flanges or tines are what hook on the trabeculi, and the J form is what helps hold it up into the right atrium. The leads on the bottom are screw-in leads, so it's the same lead, but the lead is introduced with the screw inside the housing. Once you get it in position, then you can extend the screw by spinning the pin at the other end of the lead to get the screw to come out and attach into the myocardium. All these leads now have what we call steroid in the tip, and we'll talk about that in a minute, which reduces the inflammatory process and keeps your energy demand lower. The leads on the right-hand side are epicardial leads. So if the patient had to have a sternotomy for a valve replacement or a bypass or a thoracotomy for some reason, they could implant these leads on the outside of the heart, open the pericardial sac and put them on the epicardium, either in the atrium or the ventricle, or both. The two leads on the top are stab-on or screw-on, pretty barbaric, but they still use the one in the middle there, the screw-on, to attach it to the heart. The one on the bottom is the newer type lead. It's a button lead that has steroid in the tip, and it's just sutured down to the heart. So you get a much better result with that type of lead than the other two. Different types of insulation, polyurethane or silicone, a few different advantages and disadvantages to each. And a lot of times it's just physician preference as to which they use. Polyurethane used to be very popular because there was a lower friction coefficient, so rubbing two leads together, you didn't want them to stick together because if you got one in position, you didn't want to displace it when you were repositioning the second lead. Silicone typically was more reliable and could be repaired with medical adhesive, so it had some advantages. And it depends on the physician preference as to which they like. Electrode design. Before steroid elution, we had problems with rise in threshold. So a threshold is what's the lowest amount of voltage that you can put out of the generator and make the heart beat. And when you put a foreign body in the heart, you're going to cause the inflammatory process to start. And so you start to get a big capsule around the tip of the lead. And that capsule will start to shrink after 3 months, but you're still going to have scar tissue there because of that foreign body. What steroid in the lead does is actually prevent that inflammatory process from occurring and keeps your stimulation threshold much lower for the life of the lead than if it didn't have the steroid. And we talked about polarity already, bipolar and unipolar. So stimulation and sensing. Pacemaker, in simplistic terms, does two things. It paces and it senses. So on the pacing side, you're either going to capture the heart, which means when you put out the stimulus, it's going to make the heart beat, or it's not. So the picture on the left shows you two pacing pulses, or what we call pacing spikes. You'll see it as a spike on an ECG. The first one is the atrial spike, and you can see a P wave deflection after that. The second one is a ventricular spike with a ventricular captured beat, which looks like a PVC, which is because you're typically pacing from the right ventricle and not using the heart's intrinsic conduction system, so you get PVC-like beats when you pace the heart from the right ventricle. Up on the right-hand side, you can see atrial loss of capture. Your first spike, the atrial spike, is delivered, but you have an isoelectric line and no P wave after it. So you didn't make the heart beat, you lost capture there. The diagram below shows ventricular loss of capture. You've got an atrial spike, atrial capture, and then a ventricular spike, and no response from the ventricle, so the energy wasn't high enough to make the ventricle beat. So capture is a function of the amplitude, the strength of the output pulse, and the pulse width, or the time that it's turned on. And stimulation threshold is the minimum electrical stimulus needed to consistently capture the heart outside the refractory period, during which no amount of energy will make the heart depolarize. So again, here's a strip of just a single chamber ventricular pacemaker, pacing the ventricle, and the third beat is non-capture. Sensing is the ability of the pacemaker to see when a natural depolarization is occurring. So you don't want to pace the heart if the patient's in their own rhythm or can sustain themselves without being paced. So the pacemaker usually works on a clock, and it'll wait a given period of time depending on the rate you pick. And so long as it sees heartbeats faster than that clock, it will continue to inhibit the pacing output and let the patient stay in their own rhythm. So sensing means we need to set a sensing value so that we always see, for example, an R wave, but don't oversense T waves or oversense far field sensing like P waves from the other chamber. The surface lead ECG versus an intracardiac electrogram. So what you see on the surface isn't going to be the same as what the lead sees inside the heart. The lead sees an intracardiac electrogram, which has an amplitude and a slew rate. Slew rate meaning how fast does that voltage change. So is it a nice sharp deflection, or does it take a long time for it to change, which means it's going to be tougher for it to see. The sensitivity setting, you have to tell the pacemaker what sensitivity setting you want it to be at so that it'll see R waves but ignore T waves, for example, or P waves from the other chamber, or vice versa. So here's an example of what we call the fence analogy. This one is seen to be set appropriately. The R wave, you can see by the red circle or the orange circle, is about 3 millivolts in amplitude. The sensitivity setting, the fence, is set at about 2 millivolts. And so we can see the R waves, and you can see after the R wave, there's a little T wave that's just a little bit bigger than 1.25 millivolts. That's ignored because the sensitivity setting says, I don't want to pay any attention to that. You told me anything I sense has to be bigger than 2 millivolts. And here's an example of a couple of different sensitivity settings. Now, the one on the left-hand side, the device is set too sensitive, so it's seeing the R wave and the T wave. And what's going to happen in that situation is it's going to double count, and the rate's going to be slower than what you programmed it to, because it's going to be timing off the T wave instead of the R wave, which will be roughly 400 milliseconds longer interval than what you want it to pace at. The picture in the middle is appropriate sensing, and the picture on the right-hand side is inappropriate sensing, because now the device is too insensitive. It's not sensitive enough. We've got a program to 5 millivolts, and the R wave is only 3 millivolts. So it's going to start to pace when it shouldn't pace because it's not able to see the R waves. So a key thing to remember about pacemaker sensitivity is it's an inverse relationship. If you want to make the device more sensitive, you pick a lower number. If you want to make it less sensitive, you pick a higher number. Why is sensing important? Well, back to lead integrity, insulation break, and wire fracture can cause undersensing and oversensing. And you can see in the fluoroscopic picture there with the arrow where there's a break in the lead. Electromagnetic interference from a variety of household and hospital sources can cause oversensing. Unipolar versus bipolar leads can make a big difference. You've got a bigger antenna, if you will, in a unipolar lead because it's sensing between the tip of the lead, which could be either in the right atrium or the right ventricle, and the can, which typically sits in the chest just under the collarbone. Undersensing is going to look like overpacing because it's failing to see intrinsic beat. So in this example, you can see where there's an intrinsic beat. The pacemaker tries to pace in the middle of the T wave because it didn't see it. Further on down the line, it tries to pace right after the T wave because, again, it didn't see the R wave, the intrinsic beat. And so in this case, it looks like you're pacing more than you need to, and that's typically a sign of undersensing. Oversensing is just the opposite. It looks like underpacing. My rate's slower than what I expect it to be because it's starting to sense things that aren't really there. So in this case, on the bottom is what we call marker channel. VP would stand for ventricular pace. VS stands for ventricular sense. And you can see ventricular sense markers where there really isn't a ventricular event going on, which typically is an indication there's a problem with a lead, insulation failure or conductor fracture. Here's electromagnetic interference. One of the common sources, somebody goes into surgery and they use the electrocautery to try to cauterize wounds while they're doing surgery, and that can inhibit the pacemaker if it senses it. Okay, what types of pacemakers do we have? Single, dual, and triple chamber, or what they call biventricular pacing for triple chamber, because you're going to pace both ventricles. And the real appropriate name is cardiac resynchronization therapy, because what they're trying to do with a triple chamber device is resynchronize the ventricles due to heart failure. Single chamber device means you're only going to put a lead in either the right ventricle or the right atrium, depending on the patient's condition. If they have AV block, you can't have a single chamber pacemaker in the atrium. You'd have to pace the ventricle. Somebody with chronic AF would get a VBI or a single chamber pacemaker, and we'll talk about that VBI code here in a minute. If somebody has normal conduction in the AV node but sinus arrhythmia, they could have a single chamber pacemaker in the atrium. Here's a picture of a dual chamber system, a lead in the right atrium and a lead in the right ventricle. Kind of a model mock-up on the next picture, and on the far right you can see an X-ray view, and this is a pacemaker implanted on the right side, which is pretty atypical. Greater than 90% of pacemakers are implanted on the left side. Most people are right-handed, and it's just an easier route to implant from there. Here's our triple chamber device, and you can see on the x-ray view on the right-hand side that we've got a lead in the right atrium, a lead in the right ventricle, and the other lead is in the coronary sinus, around the back to the great cardiac vein, and then down a branch, typically a lateral or posterolateral branch off the coronary sinus to try to pace the left ventricle. So how do we define pacemakers and what's the code? Well, there's an MBG code. There was the North American Society of Pacing and Electrophysiology, and the British Pacing Electrophysiology group got together and came up with a code to designate how to define what a pacemaker is. So the first letter stands for what chamber we're going to pace. The second letter stands for what chamber we're going to sense. The third letter stands for how are we going to respond to sensing, and the fourth letter stands for whether it has rate modulation or not, meaning does it have a sensor in it that can increase the pacing rate if the patient's in bradycardia and can't raise the rate on their own. So the typical pacemaker, most simple pacemaker is a VVI pacemaker. It's going to pace the ventricle, sense in the ventricle, and inhibit the pacemaker if it senses anything in the timing interval that you told it to look for. If you add the R on there, all it's saying is that I can change that lower rate interval based on activity to increase the pacing rate so the patient can get a rate response when they're active. Another one that you'll see very often would be DDD, which is a dual chamber pacemaker. So it's going to pace both the atrium and the ventricle. It's going to sense in both the atrium and the ventricle, and it can either inhibit the pacemaker or trigger an output from the pacemaker. And again, it can be combined with rate modulation. Another one that you'll not see programmed this way, but it's a temporary mode. Typically when you put a magnet on a pacemaker, if you go VOO or DOO, those are called asynchronous modes. It's not going to sense at all, so there is no response to sensing. It's just going to pace at whatever the programmed rate is in either one or both chambers. And of course you can go AAI or AOO. It's just that mode isn't very popular in the US. You either get VVI or DDD. VVIR or DDDR. We won't go through the whole schematic, but this is kind of the schema to go through. If somebody has AV block, what questions a physician might ask as to what type of pacemaker the patient's going to be best treated with. There's also a schematic diagram for if they have sinus node dysfunction. Really doesn't get as complicated as that. Like I say, most patients wind up with either a single chamber VVIR, and that's typically if somebody has atrial fibrillation or atrial flutter that's permanent or persistent, because they're not going to be able to pace or sense in the atrium. And most of the rest of the time, patients will get a dual chamber pacemaker, DDDR. Here's your basic VVI pacing mode. You set a lower rate interval. So if you set the lower rate for a rate of 60, that would convert to 1,000 milliseconds or 1 beat per second. You start the clock with a ventricular paced event, the VP there. When it sees an intrinsic event, VS, VSense, it stops the clock, it inhibits the output and starts another clock. And if the timer runs out, then it paces the ventricle again. So it's a demand pacemaker. You may hear that term used. That would be VVI or DDD. They're demand. They're only used when the patient's rate is too slow and doesn't beat the clock. Same thing for AAI. VOO pacing, here's your asynchronous mode. Typically when you put a magnet on it, or sometimes it's programmed this way for patients to go to surgery, it's just going to pace at whatever the programmed rate is. Here it's 1,000 milliseconds, which would be a rate of 60. And you can see that patient's intrinsic beat comes through in the third beat there. It's ignored because it's asynchronous. DOO pacing, the same thing. DDD pacing can be very confusing initially until you understand it, because it basically has 4 phases that can all be normal depending on whether the patient is beating the timer. So you can have A-sense, V-sense, which is nothing more than normal sinus rhythm. You can have A-sense, V-pace, where it's sensing the atrial events, but the patient's not conducting through fast enough to the ventricle, so it winds up pacing. Or you can have A-pace, V-pace, which is what most people expect to see with a dual chamber pacemaker, pacing both chambers. Or you can have A-pace V-sense, where you have sinus bradycardia, for example. So it paces the atrium, but you have a normal PR interval, so it conducts down fast enough for it to have an intrinsic beat. And here's what they look like. This is just sinus rhythm, and the pacemaker just sits back and marks it for you and says, okay, I saw both of those, A-sense, V-sense, atrial sense, ventricular sense, and leaves it alone. Here it says, okay, I saw a P wave, atrial sense. The timer for the AV timer times out. It says, okay, I didn't see an R wave fast enough, so I'm going to pace the ventricle. And so you have A sense, V pace. This would be typical for somebody with complete heart block. Here's A pace, V pace. Maybe somebody's got sinus bradycardia and complete heart block, and you'll just see it pacing both chambers all the time. And this is typical of somebody who might have sinus bradycardia but normal AV conduction. Paces the atrium and conducts down normally, so you have A pace, V sense. DDDR just means it's going to increase the rate based on a sensor within the device. Most of the sensors out there are activity sensors or piezoelectric accelerometers. There are others like closed loop stimulation that looks at impedance measurements in the right ventricle or right atrium to increase the rate, or minute ventilation, which looks at transthoracic impedance to try to determine what the heart rate should be. Okay, we'll go through this one fast. I just wanted to show you this to show you all the different timers that are in a pacemaker. There's blanking and refractory periods to try to prevent sensing something on the atrial channel that's going on in the ventricle and vice versa. There's an AV timer. If we go down to the bottom of the screen, the AV timer and the lower rate interval timer and an upper tracking rate timer. So in other words, you can tell the pacemaker not to pace faster than a given rate, say 120 beats a minute. And the lower rate interval is typically around 60 to 70 beats per minute. Magnet operation. When you put a magnet on a pacemaker, it's going to cause it to go asynchronous. So you're going to get typically a rate of somewhere between 85 to 100 beats a minute, depending on the manufacturer. And it can also tell you when you're at replacement time, because without a Medtronic, the magnet rate, if it goes to 65, that device needs to be replaced because the battery has reached replacement time. It's a good way to prevent oversensing. For some surgeries, it's fine just to put the magnet on to let it asynchronous pace. This, we're not going to go through piece by piece, just to show you that different manufacturers have different pacemaker rates. BOL at the bottom of the screen here stands for beginning of life. ERI, ERT, that means elective replacement indicator or end of life. So it's just showing you the different rates when you put a pacemaker on. So it can also help you determine which company the pacemaker is. If you put a magnet on and you get a rate of 85, it's Medtronic. If you get a rate of 98.6, it's probably St. Jude. If you get a rate of 90, it may be Biotronic. So it can help you identify which company it is. Okay, getting into ICD technology. Besides all the things, the pacemaker, a defibrillator will do all of that, plus it has therapy for people with ventricular arrhythmias. So the ICD system is used to treat abnormal heart rhythms like ventricular tachycardia and fibrillation. So life-threatening rhythms can cause sudden cardiac arrest. Now most patients will get a defibrillator based purely on their ejection fraction. If you've got an ejection fraction of less than 35%, you're a candidate for a defibrillator. When I first started working in the business back in 88, 90 area or 1990, when we started getting defibrillators, you had to survive 2 sudden cardiac death episodes before you were a candidate for defibrillator, and then you had to have an epicardial system, which they had to do a sternotomy, open you up, put patches on the heart, and bury the device in your belly. And now the device is much smaller and can be put in transvenous through the subclavian vein again. How effective are they? Well, 98% of people survive a lethal arrhythmia when treated with defibrillation. Only 5% of people survive a sudden cardiac arrest without defibrillation. So these are like a mini trauma unit in your chest. They automatically detect and treat before anybody could possibly get there in time to treat you. How does it work? Very similar to a pacemaker. You've got a device and either 1, 2, or 3 leads. Here we have a dual chamber system, a lead in the atrium and a lead in the ventricle. This device is capable of anti-tachy pacing. So for like ventricular tachycardia, you can try to pace them out of the arrhythmia rather than shock them out of it. It's also capable of cardioversion for VT if pacing doesn't work. and defibrillation for ventricular fibrillation. On the atrial channel, depending on the manufacturer and the device, there's also some anti-tachy pacing capability for things like atrial flutter or preventing atrial arrhythmias. Here's your device, defibrillator broken down. It's pretty much the same as a pacemaker, except now they've added a capacitor, because most pacemakers and defibrillators batteries are about 3-volt output, which is fine for pacing. But if you're going to shock somebody, you're talking 35 to 40 joules, which is like 800 or 900 volts. Well, to get that 3-volt battery up to 800 volts, you have to use a capacitor to charge it up, then deliver all of that at once to shock them out of the arrhythmia. And how does it do it? Well, it delivers the energy from the coils. These leads have coils on them, not just a cathode and an anode like a pacemaker lead. They also have those big coils you can see on the illustrations here. The energy is delivered from those coils, typically from the right ventricular coil to the CAN and or the SVC coil, the superior vena cava coil, or if it's a single coil lead, just from the coil to the CAN. The idea is to get the lead out in the right ventricular apex as far as possible, so you get as much of the septum in between the CAN and the coil to shock as much of the ventricle as possible into normal sinus rhythm again. Major functions, sensing is very critical, and we'll talk about how the sensing algorithms work. It's a little different than a pacemaker. It detects dangerous rhythms. It's going to provide pacing and defibrillation, and one of the very important things is it stores diagnostics. These devices will store every time your heart rate goes over a certain rate that you program into the device. It'll tell you the time and the date it hit that rate, how long it was there, whether it needed therapy or not, whether it was effective. It'll store electrograms and show you exactly what happened. With sensing, with a pacemaker, you pick a particular sensitivity setting, and it's a fixed setting. So we talked about 2.5 millivolts or 3 millivolt sensitivity setting. With a defibrillator, you need to be able to sense ventricular fibrillation. So a 2 to 3 millivolt sensitivity sensing isn't going to work. Typically, we program the sensitivity setting to like 0.3 millivolts or 0.5 millivolts so that I can see fine VF. Then we have to do something called auto-adjusting sensitivity so that whenever it senses an R wave, it's going to bump the sensitivity setting up 75%, 100% of what the R wave was, and then bleed the sensitivity setting back down to 0.3 or 0.5 millivolts so that we miss T waves during normal sinus rhythm, but are still sense enough to see VF. And detection zones. You can tell the device what rhythms or what rates you want it to call certain things. So for VF, the VF zone is typically programmed around 320 milliseconds to 300 milliseconds, which would be like 290 to 300 beats a minute. Typical ventricular tachycardia zone, we programmed about 150 beats a minute or 400 milliseconds. And then your normal sinus rhythm zone is anywhere from the low rate, typically 60 up to 150 beats a minute. The device has marker channel, we call it, to tell, it'll tell you when you interrogate the device what it's been thinking. So TS would be a tachysense for like VT. TD means it has detected ventricular tachycardia. FS means it's a fibrillation sense. It's in the VF zone. And FD means it detected fibrillation. Why is sensing appropriate? Well, here's two examples of inappropriate sensing. The top strip, if you look at the bottom part of the top strip, you can see a lot of VS markers. And then you get about to 2/3 of the way through, a little break in the screen, and it says aborted. It means the shock was aborted. And you only see occasional V-sense markers, but you can still see the patient is clearly in ventricular fibrillation. This device is undersensing terribly, and the patient is not going to receive therapy because it's not seeing the VF. If you look at the tracing below, here's a tracing of a patient that's oversensing. It's sensing not only the R wave, but the T wave, so it's double counting, and it thinks the device thinks the patient's actually in VT when it's just oversensing the T wave. So either one of these is bad. That's why the auto-adjusting sensitivity algorithm is so important to defibrillators, or ICD is implantable cardioverter defibrillator. Detection, basically it works on rate and number of intervals. So you can tell the device you have to be faster than 188 beats per minute in this example for VF, and you have to be in that rhythm for at least 24 out of 32 beats. If it was VT, in this case it says it's turned off, but here it would be 167 beats a minute, and you'd have to be there for 16 beats before we'd call it a true ventricular tachycardia episode. So ventricular tachycardia is typically regular intervals and monomorphic, less susceptible to undersensing. VF is polymorphic with irregular intervals, more susceptible to undersensing. And so the VT zone and the VF zone use different ways of counting to get to the point where it says it's in an arrhythmia. For VT, once you've hit the fast rate, then you have to stay there for a consecutive count of, in this case, 16 intervals, but that's programmable. But it has to be consecutive because VT is typically very stable. VF, however, because of its irregularity and unstable nature, we typically use a probabilistic counter where it says you have to meet typically 75% of the beats. So 30 out of 40 beats, or 12 out of 16, or 24 out of 32, whatever the case may be, it has to meet that many beats for it to call it VF. You can program several different zones for a defibrillator. Here we can take a look at, on the top panel here, a device that's set up for VF, 180 beats a minute. It has a fast VT zone of 350 milliseconds, so between 170 and 188 beats per minute, and a VT zone of 150 beats a minute. So the yellow are the VT zones, the orange is VF. It also has a monitor zone. That little white square says anything that's faster than 133 beats per minute up to 150. We're not going to treat it, but we're going to record it so that we can look at it for diagnostic purposes. The blue box is something we won't get into very much in this presentation, but that's what we call our SVT discriminator zone. So supraventricular tachycardia can trick the device. So if you have atrial fibrillation with rapid ventricular response, it could trick the device into shocking the patient inappropriately. And so there's quite a few different little algorithms you can program on to prevent that from happening. Another practical application here, when you put a magnet on a defibrillator, it works different than a pacemaker. It's not going to affect pacing function at all. What it does is suspend detection. So as long as the magnet's on, it's not going to detect or treat, which can be good for some types of surgeries, to not have to turn the device off, just put a magnet on it. Or if the patient's being shocked inappropriately, you can put a magnet on and stop the inappropriate shocks until a representative can get there, or until the patient can be transferred to an ER. Okay, so different types of therapies for a defibrillator. You've got Brady pacing, anti-tachy pacing, cardioversion, defibrillation, and ATP before and during charging. I'm going to skim through some of these. We talked about Brady pacing and pacemakers. It's the same for a defibrillator. Anti-tachy pacing, this would be geared primarily towards ventricular tachycardia. Instead of getting a painful shock, the device can try to pace them out of it by pacing at a rate a little bit faster than the VT to stop the arrhythmia. And here's an example of where it was in VT, tachy paced, and then went back to normal sinus. Different ways of presenting it in terms of percentage of the arrhythmia and how many sequences you're going to give. Cardioversion just means it's going to try to synchronize on an R wave when it shocks. In VT, defibrillation shock, it's still going to try to synchronize, but it doesn't need to do that. It will try to synchronize. If it can't, it's just going to shock, because you got to get somebody out of VF. And here's an example of somebody in VF. They could say a 35 joule shock. You can see it down at the bottom. It says 35.6 J. And you can see them return to normal sinus rhythm. Here's how you program the output. 6 therapies. So the device will give the patient 6 tries to break the arrhythmia at 35 joules. Again, how the energy is delivered from the coils to the can, or you can reverse polarity and go from the can to the coils. Getting into heart failure a little bit. Heart failure is a complex clinical syndrome which the heart is incapable of maintaining cardiac output adequate to accommodate metabolic requirements and the venous return, caused by abnormality of cardiac function. Heart failure can be due to a weak heart and the inability to pump blood out of the heart, systolic, which is what we treat, or it can be a problem with filling of the heart due to the stiffness of the muscle, diastolic, which pacemakers haven't been effective in helping treat. Systolic dysfunction is 70% of the patients with heart failure. Then they have an EF, ejection fraction, of typically less than 40%. And if you have an ejection fraction of less than 35%, you're at risk of lethal arrhythmia. And if your QRS complex is greater than 150 milliseconds, you've got bundle branch block or interventricular conduction delay. Now you're a candidate for a biventricular pacemaker defibrillator, or what we call a cardiac resynchronization therapy device. Here's just a quick overview of normal systolic dysfunction and diastolic dysfunction. Basically, the left ventricle starts to get enlarged, the muscle gets weak, and it can't contract fast enough, and so you start to get dyssynchrony between the right and left ventricle. Here's your different classes of heart failure. Typically, we're looking at treating patients with class 2, class 3 heart failure with a cardiac resynchronization therapy device. Class 1 typically isn't severe enough, and class 4 is past the help of a defibrillator and typically needs something like a left ventricular assist device or a heart transplant. Some of the reasons that heart failure can be caused, we're not going to get into that beyond the scope of this presentation. Some of the signs and symptoms, I'm sure you see this with patients every day. Some of the treatments, again, we won't get into this too much, but your basic therapies, drug therapies, patients have to be medically optimized before they qualify for a device. So in stage B and stage C, they would have to be on all these therapies for a given period of time before they could qualify for device implant. Heart failure can be a vicious cycle. If the patients don't stay on their meds and don't follow their lifestyle changes, they wind up in the ER and hospitalized, and they come back to see the doctor, and it goes round and round. It can be very costly to the healthcare system. How do they treat heart failure? Non-pharmacological therapy, which would be lifestyle. Pharmacological therapy we just kind of looked at, and surgical therapy, which includes devices. So I'm sure you're all very familiar with non-pharmacological therapy. Reduce fluids and sodium, get your physical activity, stop smoking and alcohol or greatly reduce it, find the right family and friends to support you, and avoid NSAIDs and channel blockers. Here's the pharmacological therapy, which we saw in the previous slide. Surgical therapy, EP intervention, ICD, CRTD or CRTP, or an ablation for VT. They can actually go in and find scar tissue and ablate it so it stops the ventricular arrhythmia from happening. Revascularization typically needs to be done before, if that's indicated, needs to be done before you get a device, because revascularization can help improve ejection fraction. Valve replacement, and the other ones, ventricular restoration surgery is not really relevant to the type of heart failure we treat. ECMO is class 4, where they're doing extracorporeal membrane oxygenation. LVAD, transplant, complete artificial heart, that's phase 4, or New York class heart 4, we're 2 and 3. Despite improvements in medical therapy, symptomatic heart failure still confers a 20 to 25% risk of premature death in the first 2.5 years after diagnosis. 50% of these are due to sudden cardiac death, VT and VF. That's why device therapy was indicated. Moderate to severe heart failure population has quite a bit of interventricular conduction delay, and those are the patients that are going to respond to biventricular pacing. Here's just a picture of a large hypertrophy left ventricle, the type that typically are going to be treated with pacing. Here's your ventricular dyssynchrony. The top strip shows the bundle branch block or interventricular conduction delay. If it's greater than 150 milliseconds and you have an EF of less than 35%, you're a candidate for a biventricular cardiac resynchronization therapy device, either a pacemaker or a defibrillator. Typically is the defibrillator, unless the patient is heading for hospice and just wants palliative relief and not necessarily life-saving therapy. Here's what our resynchronization therapy device looks like implanted. You're going to put a lead in the right atrium, one in the right ventricle, and then the physician has to find the coronary sinus, which is a little hole in the right atrium, which leads into the vein that goes around the back of the heart, and then a branch off of that vein that goes to the lateral side of the heart to put in his left ventricular lead. That lead is usually programmed to pace anywhere from 20 to 30 milliseconds faster than the right ventricle to give the left ventricle kind of a head start so that they start to resynchronize. And you can actually remodel the heart with this therapy. And then the other part that's important is to program the time between the atrium and the ventricles appropriately to maximize cardiac output. Here's just a diagram of what the coronary sinus and its branches look like. That coronary sinus, great cardiac vein, actually goes behind the heart and comes around to the front. And the lateral branch is typically the best branch for pacing the left ventricle. Here's what it looks like on fluoro. These pictures are a little bit old because now they have leads for the left ventricle that are, instead of just bipolar, actually have 4 electrodes on it to either be able to optimize where you pace from to stimulate the left ventricle in the most appropriate place, and or pace from more than one of the electrodes, multi-point pacing they call it. So in summary, heart failure is a chronic progressive disease and that's generally not curable but treatable. Most recent guidelines promote lifestyle modifications and optimal medical management. Estimated 50% of all heart failure patients may be candidates for cardiac resynchronization therapy. And close follow-up of the heart failure patient is essential with necessary adjustments in medical management. And with that, I've come to the end of our slide deck. I want to make sure I've left enough time for questions. So if anybody has a question, I'll be happy to answer that. Don't see any questions coming through right now, so I either was amazed.
There's a question from Peggy Krause. Can a device be an ICD without the ability to pace?
No, defibrillators lack pacing therapy. So you'll have single, dual, and biventricular defibrillators, just like you'll have single, dual, and triple chamber pacemakers. So somebody that gets a single chamber ICD is somebody who probably has an EF of less than 35%, but doesn't have any type of bradycardia indication and doesn't have a wide QRS complex, so isn't a heart failure patient yet. So they typically get a VVI pacemaker defibrillator that is programmed usually at a rate of about 40, just as a backup. And so it's used primarily for anti-tachy pacing or defibrillation, and the pacemakers are just in case they need it in the future. Or many times they need some support right after a shock. So for several seconds after you get shocked, you may be bradycardic. The pacemaker can actually be programmed to a rate faster than the typical low rate. So like rate of 70 beats a minute after you get shocked for a given period of time, and then it goes back down to the low rate of 40 or 50 beats a minute.
Great. So got one more question here, John. But will the pacemaker always be programmed, or maybe it's programmed to be inactive?
They never really turn it off. They just, like I said, they'll just program it to a rate that's so low that you're never going to see it work. So the single chamber pacemaker or single chamber defibrillator is the only time you'll see a device programmed to a rate of 40 or something like that, where they know they're not going to need the pacing, but they want it there as a backup after shock or for the anti-tachy pacing capability. Once you get into like a dual chamber defibrillator, now that patient not only has an EF of less than 35%, but they've also shown some type of bradycardia indication, like one of the AV blocks or sick sinus syndrome.
Great. I think that's the end of our questions. So
I could a little slower.
I want to thank everyone for their time and attention with your presentation. And just to remind everyone, you'll be receiving an email from me that will contain a link to the video recording and as well as your CEC. Just give us about a day to get that stuff out. Again, thank you very much.
If you want to include my email on that, I'm happy to answer questions after the fact if they want to send me an email or something.
Will do. Thank you.
You bet.